Hey y'all. I just wanted to come on really briefly and do a quick cardiac review. As we're concluding this month, I haven't done one all together recently, so I just want to quickly hit over the topics that you should be familiar with. I was doing a one-on-one session and I was getting some questions on hypertension and the current guidelines that are being tested. I know I recently did a video on the current test blueprint for ANCC as well as AAMP. So I wanted to go through this again to kind of give you and make sure that everybody's up to speed where we are for test purposes. So what they are currently testing on is what I will be going over in a short and sweet fashion to try to give y'all an idea and so how you can study and structure your studies, I should say. But I always start with a disclaimer. For those of you who are familiar with me, seen my videos, done any of my courses, have any of my resources, hey y'all. Hope y'all are doing well. For those of you who are new to me, welcome, 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 y'all. I'm Dr. Brittany Weinstock. I am a family nurse practitioner and I am the founder and CEO of the Nursing Studio. I do this to assist nurses and nurse practitioners with being successful on boards as well as in practice. So I provide these resources as tools for you guys, but we know there are no absolutes in medicine. So we treat on a patient by patient basis. I will deliver these things in the guidelines and things as the test is currently on. And like that's what I was just explaining, that I had a question from one of my reviewers about which hypertensive guidelines we are following, but I'm always going to tell you what we're currently testing on. Now, when we're speaking on how we're currently practicing, it may vary some based on when the test is updated. So I will always say, hey, in practice, we are currently doing versus, hey, this is what we're doing for test purposes. Now, a lot of times I get some pushback about hypertension, and I don't know why. It gets down to these medications, but y'all, I am only telling you the guidelines that we are currently testing on. This is for board preparation. I know that we do things a little bit differently in practice. Look, cardiology is my background. I know it. I got it. Trust me. I'm telling you this not by a guess or on a whim. I'm telling you what I know. So I'm just letting you know to prepare you. So if you're hesitating or wondering why I'm saying this, it's strictly for the purposes for board preparation. Okay, you guys. All right, let's get into it. I know I just said a mouthful, but I don't want you to be confused or swayed or having a question. So I like to kind of give you a foundation of where I move from and why I'm saying the things that I'm stating. Okay. So hypertension. We are currently, the guidelines on boards are testing based off of ACC and AHA guidelines. Okay. The ACC and AHA guidelines. Now, there are some out since for 2023, but the test is from the, it hasn't been updated since the 2021 guidelines, and it's still the same. So don't get confused, okay? We're no longer doing JNC8. We are doing ACC and AHA guidelines. If it sounds like I'm on a soapbox, I am. Because I get this all the time. But listen, ACC and AHA guidelines is what we're currently testing on. And it goes like this, you guys. All right. So we always know our 120 over 80 has always been that marker that we know for blood pressures, right? And with that, we still follow that standard. We want our patients to be around that range. If they exceed 120 over 80, you consider that pre-hypertensive stage, and we start to incorporate those lifestyle modifications, right? Remembering your lifestyle modifications to be exercising 5 days a week for a minimum of 30 minutes on each of those days, incorporating that DASH diet where we have a low sodium, in the diet, would be implemented for those that are exceeding that 120 over 80. Now, this is where things kind of change. We're not looking at age, we're not looking at race, we're looking strictly at comorbidities and their current blood pressure. If a patient has comorbidities, we do not want their blood pressure to exceed 130 over 90, right? If it's exceeding that 130 over 90 range, then you need to initiate treatment. Meaning, hey, we already should have lifestyle modifications in place because they have exceeded that 120 over 80. If not, you're going to always do that. We're going to have that on board, right? So lifestyle modifications, and then you want to make sure that you're implementing a medication now at this point. So they have comorbidities, they're diabetic, they have chronic kidney disease. If they have other chronic illnesses and comorbidities, you want to implement something if they're exceeding that 130 over 90. Why? You already have risk factors. We don't need an increased blood pressure to add on to that, right? We're trying to protect your heart as much as possible. So, with that, initiate therapy. I'm going to get into treatments in just a second because this is where some confusion comes into place. Next, if this patient is healthy, does not have any comorbidities, then we do not want their blood pressure to exceed 140 over 90. Okay. If they are healthy without any comorbidities, we do not want their blood pressure to exceed 140 over 90. If it does, in fact, exceed 140 over 90, then we initiate therapy. So, what's the therapy, right? Same thing like we've been doing. You can start with your thiazides if they don't have any allergies. You start with your thiazides, and then we work it from there. So, if they have chronic kidney disease or if they're diabetic, we want to go with the ACE or ARB to protect those kidneys. And you also know that the African American population responds best to thiazides and or calcium channel blockers. They actually respond best to combination medications. Now, I know that we utilize so many different blood pressure treatment options, hypertensive medicines for our patients when we are in practice. For but for board purposes, our patients, first line therapy, you want to go with that thiazide unless they have chronic kidney disease or diabetes. Then we start with those ACEs or ARB, okay? And then you work your way through. Remembering, if you prescribe a thiazide, remember, if they have a sulfa allergy, you don't want to give it to them. If they have gout, you don't want to give it to them. And you also want to make sure to watch their electrolytes because of the varying electrolyte imbalances associated with thiazides, okay? Also, with your calcium channel blockers, we don't want to give these to patients with severe cardiac issues such as heart failure and or AV block, okay? Now I just kind of throw this out there because I do get questions about should you know EKGs or should not. Now, throughout the years, there has been EKGs, maybe one periodically on certain exams. So I always say, hey, familiarize yourself with those basic rhythms, right? Like your normal sinus rhythm, your sinus bradycardia, sinus tach, AFib, A flutter, VTAC, things like that. You should definitely be able to identify. But on the blueprint, we haven't seen EKGs listed. Okay, so but just be familiar with it. Okay. All right, cholesterol. Let's talk cholesterol a little bit. So, first you want to know your lipid panel. We're talking total cholesterol, LDL, HDL, triglycerides, right? We want that total cholesterol to be less than 200. We want our LDL to be less than, so it's a few things. So, for testing purposes, the overall goal is less than 120. Our cardiac people, you want less than 100. But if they have comorbidities, you want less than 70, okay? So, again, the standard healthy person, LDL, you remember L for lousy, we want low. That's your bad cholesterol, right? So, we want that less than 120 for our healthy population. Now, cardiac wise, if we're starting to talk about somebody with a cardiac history, you want it lower for those heart risk effects and things, risk factors is what I'm trying to say. But you want it lower, right? And so if this person has a comorbidity, you want it less than 100. If they have multiple comorbidities, you want it less than 70, okay? HDL, I always say think happy. You want HDL to be high. H for HDL, H for happy, H for high, because this is our good cholesterol and it helps to bring down that bad cholesterol. Exercise can also help to increase this number, and we want it to be greater than 40, okay? And then our triglycerides, we want less than 150. Now, if the triglycerides exceed or 500 or higher, you want to consider pancreatitis for this, okay? And then I'm going to speak on that a little bit more when we start to talk about treatments. But when we start to have abnormalities, you know, your for cholesterol, so high cholesterol, we want to do like we do with anything else. You want to initiate lifestyle changes. So again, incorporating low cholesterol diets, that DASH diet with the low sodium, telling them to exercise those 5 days a week, at least 30 minutes on each of those days. Okay, when we're talking cardiac, that's your go-to, right? But we want to consider therapy. So this is what you see here: statins, niacin, phenofibrate. You know, when I give y'all mnemonics and different little things, I like to say Brittany's brilliance, right? So for this, I always say SNF, like sniff, like a skilled nursing facility. SNF. We want to start with a statin. Next is our niacin, and then we finish with a phenofibrate. Meaning, hey, we're gonna put you on statin therapy, right? And we will go and max out that statin therapy. But if you're not to go, then next is a niacin. We want to throw in a niacin with it. If that doesn't work, we finish with a phenofibrate, right? Now, if those triglycerides are 500 or greater, you start with a niacin. So again, we start with a statin, next is the niacin, finish with the phenofibrate. Unless the triglycerides are 500 or greater, then we go directly to a niacin for treatment, okay? Heart failure. Make sure when you are reviewing heart failure, your congestive heart failure, that you understand and know your NYHA classification. You know there's four, right? So let's just break down heart failure a little bit and then I'll get into it, because you know with heart failure, that's when your heart is having that difficulty adequately pumping the blood throughout the body, right? For various reasons. We have right and left heart failure. With left heart failure, we typically have those respiratory systems. We always say think about the lungs. Left, L for lungs, right? So they'll have more of that shortness of breath, dyspnea on exertion. And so when we think about this, I want you to think about those NYHA classifications, which is the breakdown of that. Um, with the NYHA classifications, and I'm trying not to give y'all too much. So if you hear me pausing, I'm just trying to break this down in a short and sweet fashion so that you can think about it a little bit easier. But there's four. You know, whenever I discuss ranges, I tell you guys to think of the smaller end, the larger end, and then everything that falls in between. So with NYHA classification, class one, they have absolutely no restrictions or limitations with physical activity, right? Whereas with class four, they had those limitations with activity and rest, right? So class one, absolutely no restrictions, no limitations. Class two, they start to have some slight restrictions. They may start to have some shortness of breath on exertion. You know, they might start to notice and mention it to you. Hey, yeah, I am getting winded. When I exert myself after a while, right? Class three, they definitely know they have limitations. Hey, when I get up and I walk to the mailbox, I am winded. I'm so short of breath. You know, they notice it. They're telling you about this. And then class four, they have those constant limitations. Hey, I can't get up and walk to my bathroom uh, from the bed to my master bath without getting winded. Hey, when I lie flat, I feel like I'm drowning. I can't breathe. Orthopnea, right? So class four, no restrictions, no limitations. Class two, they slightly have some shortness of breath, some limitations. Three, those definite limitations, they are short of breath, winded. And then stage four, they are winded and having these limitations at rest and on exertion, okay? All right. Murmurs. We've been hitting murmurs a lot. We just recently did questions on murmurs. So I'll go through this really quickly, but you know, I always tell you guys when we are covering murmurs for testing purposes, make sure that you know systolic versus diastolic, the location, signs and symptoms you should be familiar with. But when you're trying to quickly get this answer, look for these key things in the scenario, right? Systolic versus diastolic and the location. So there are many mnemonics. Go with whichever one works best for you. My Brittany's Brilliance, I say for systolic, I call her Sassy Systolic, says men really are stupid. Men really being mitral regurgitation are stupid, aortic stenosis, right? And MVP, mitral valve prolapse, also falls under these systolic murmurs. And then diastolic are simply the opposite. So the opposite of mitral regurgitation will have mitral stenosis, and then the opposite of aortic stenosis is aortic regurgitation, right? So systolic versus diastolic, knowing that, right? So you can narrow down which one fall in that category, and then the location. So also I want to say real quickly with systolic, remembering systolic murmurs are the ones that radiate. So that mitral regurgitation radiating to the axilla, and then aortic stenosis radiating upward to the neck region, right? Think about the location of these things. But location, we have aortic, which is at the second intercostal space at the base of the heart, right? So the second, I say, think A comes first in the alphabet. So it's at the second intercostal space at the base, which is higher uh, anatomically of the heart, right? And then mitral, M comes after A, is at the fifth intercostal space, mid clavicular line, and it's at the apex. Again, I know we think base bottom, but the apex is lower than the base of the heart. So again, make sure you know your systolic versus diastolic in your location, because when it gives you a scenario, you're going to be able, okay, they said it's a systolic murmur. I can narrow it down to these. All right, it'll say either at the base, it'll say fifth intercostal space, mid clavicular line. It's going to say these things so that you can narrow down what they're talking about, right? Also knowing those key identifiers with these murmurs, whereas mitral regurgitation is holosystolic, again, radiating to that left axilla. Um, MVP, you will hear a click. A mid-systolic click is very common. I always tell you guys when studying, know those key identifiers because that's what they're going off of. They're going to ask you, if it's a key identifier, they're going to ask you about the key identifier. Um, aortic stenosis has a harsh sound. Mitral stenosis is more low pitch. Aortic regurgitation high pitch. And then murmur grading. I don't want to get too deep in and make this lengthy video. I have some videos on it, but it gradually increases. There's 6 grades of your murmur grading, going from grade 1 being barely audible to grade 6 where there's a thrill and you can hear the murmur without placing your stethoscope all the way on their chest, honestly. Remembering that grade 4 murmurs is where the thrill is first noted, okay? So really quickly, because I feel like I just said a whole bunch and y'all say I talk fast. Murmurs, make sure you know systolic versus diastolic and the location, right? Right? Identifying that systolic versus diastolic. Systolic murmurs. Men really are stupid, being mitral regurgitation and aortic stenosis, and MVP also falls under there. These are the ones that radiate. And then diastolic is the opposite, mitral stenosis and aortic regurgitation. Location, aortic is at the second intercostal space, the base of the heart. Mitral is fifth intercostal space, mid clavicular line at the apex of the heart, right? Murmur grading, grade 1 through 6. Grade 1 is barely audible. Grade 6, there's a thrill, and you don't even have to place your stethoscope on their chest to hear it. Grade 4 is the first murmur grade where a thrill is notated, okay? I'm just giving you the high points. If you want to go more in depth, I have courses. I do one-on-one sessions, and we can drill through your weaknesses until I make them your strengths. That's what I'm here for. I'm the I've been coined the test taking tactician for a reason. I got tactics that's going to get it through to get you from, if you've been unsuccessful, to successful. If this is your first attempt, getting you where you feel weak to being confident and strong in those weak areas. But with these videos, I don't like to overwhelm you or overload you. So if it seems like I'm hitting it quickly, I'm just trying to give you the rundown so that you can quickly identify these things. So when you're studying, then you can think back and say, hey, she did say, just look at these key points, or hey, this is what she mentioned. Let me make a note of that. So that's what this is mainly designed for. But if you need me for more in depth things, let me know. But this is the short and sweet version. All right. And last little thing I want to hit on is PAD versus CVI. So peripheral artery disease versus chronic venous insufficiency. Y'all know Brittany's brilliance. You've seen my videos. If you haven't, then take a moment. With PAD versus CVI, one of the reasons like I really like to hit into this is because it can easily be confused, right? Because sometimes like exams, if they show images or if they're describing it, a lot of reviewers get mixed up. We know it can show different issues with the extremity, which versus which, right? So I like to break it down and then make it a little bit easier for you to be able to identify and retain. So PAD is an issue from the arteries, right? Peripheral artery disease. And CVI is an issue with the veins, right? Chronic venous insufficiency, right? So you need to know how the arteries work versus how the veins work, and then you can work your way backwards in these question formats. So I always say, I think about Usher's song, right? You know, in the song he'll say, "Peace up, A Town down," right? Mm-mm, mm-mm. So peace up looks like a letter V, right? A town down, the A is pointing down. So PAD, A town down, arteries for A town down. Arteries pull blood from the heart down to our lower extremities, right? Whereas peace up, the peace sign, peace is up, looks like the letter V, is pointing upward. Your veins bring blood to the heart, right? So if you have chronic venous insufficiency, that's like your DVTs. You're gonna have the varicose veins. You're gonna notice all that bulging or issues in the lower extremities because you have an insufficiency. So the veins are unable to bring that blood from the lower extremities back up to the heart. Whereas PAD, where you have an arterial deficiency, your arteries are deficient. Remember, A town down, we pull blood down from the heart to our lower extremities. If we have deficiency with that, that means you're not getting good blood flow down to the lower extremities. So what happens? There's lack of hair growth. It's cool to touch, right? They might have that shiny skin, and it's because there's not a good blood flow and circulation coming back down to the heart, okay? Because peace up, A town down, right? Peace up, the venous is bringing it to the heart. A town down, arteries are bringing it from the heart down to the lower extremities. All right, again, I know short and sweet, but I just wanted to give you that really quickly to help you kind of think through. Pause it, take notes as you're studying to get those little key tips, okay? Now, if you have any questions, if you have any questions for me, any concerns, any topics you want me to cover, if you need me to slow down and do a specific video on a specific area to help you practice questions on those areas, please let me know. Now, we will be doing practice questions all next month. That's what we're hitting. Our March Madness, we will be hitting through all of those questions, okay? So let me know in the comments if there's any particular area that you need me to help you with and cover, okay? And as always, thank you so much for watching. But please be sure to make sure you like, comment, subscribe. It's free to subscribe. It helps me as I'm helping you guys. But make sure that you are like, commenting, subscribing, and sharing with whomever you may think may find this beneficial as well. But you know, as I always tell y'all, make sure you meet me back here. If you need to contact me, you see our contact here for the nursing studio. Our telephone number is 803-400-6864, or shoot me an email at thenursingstudio1@gmail.com. We do offer one-on-one sessions if you have any weak areas, if you want to go through practice questions together, if you just need me to test and see if you're ready for exams as you get closer. Shoot us a message. We'll get you scheduled out for one of those sessions or however many that you may need. We do have another 5-week course that will be coming up in a couple of months, but you will see that. We do have a practice question course coming up, and I do have self-paced resources, review books online. So whatever you need, let me know so that I can assist you. But make sure you meet me back here. All right. Bye, y'all.